kanski lecture series, and this is going to be the part 2 of the lacrimal drainage system. We had a bit of the distortion or disturbance in the previous lecture, so we will start from there. So basically we were discussing about the irrigation of the irrigation investigation of the lacrimal drainage system. So basically irrigation is done to rule out the location of the obstruction. So irrigation is done. So first of all, what you do is basically put the syringe. You dilate the punctum with the punctum dilator, and after that you place the probe and a cannula, and you first go vertically, then horizontally because of the anatomy of the lacrimal drainage system, and then you feel that if it is a hard stop or a soft stop. So we were at the hard stop. Basically, when you feel that there is a hard stop, it means that there is no obstruction between the punctum and the any canaliculi. The canalicular system is patent, so that is why you are feeling the um, lacrimal sac, and you are feeling the bone that is adjacent to the lacrimal sac. So it means that there is a patency of the canalicular system. So after that you do the syringing. So there will be the multiple things that can happen after the syringing. One, the patient may feel the patient may taste the saline. If the patient tastes the saline, it means that there is no obstruction, or there can be the partial obstruction or stenosis. But if there is still a patient complaint of the watering from the eyes, that can then be we can rule out by the Jones dye testing. Second is that a patient does not feel any kind of taste in the mouth, in the nose, and after that there is also the reflux from the upper and the lower canalicular system due to the reflux of the lacrimal sac material. It means that there is an obstruction at the nasolacrimal duct. So another thing is that a soft stop. The soft spot is experienced if the cannula stop at or proximal to the junction of the canaliculi, common canaliculus, and the lacrimal sac. The sac is thus not entered. A spongy feeling is experienced as the cannula presses the soft tissue of the common canaliculus and the lateral wall against the medial wall of the sac and the lacrimal behind it. As a crimped canaliculus with occlusion of the cannula tip against the canalicular wall can give this impression. It is worthwhile slightly retracting the tip, increasing the lateral tension on the lid, and gently repeating the attempt to advance the probe. In a case of a lower canalicular obstruction, a soft stop will be associated with the reflux of the saline through the lower punctum. Reflux through the upper punctum indicate the patency of the both upper and the lower canalicular obstruction of the common canaliculus. So basically, in a case of a canalicular obstruction, there will be the soft spot stop. So soft stop mean that there is a spongy feeling, that when you pass the syringe you will have a spongy feeling. So you know that the anatomy of the lacrimal drainage system, that it is basically the upper puncta, and there is a canaliculi, and both of these form the common canaliculi, and there is a lower puncta, and then there is a lower canaliculi that form the common canaliculi. So what happen is that if you put the syringe and you irrigate the syringe, and there is a reflux from the same side of the punctum, it means that obstruction is in the somewhere in the lower canaliculi. But if you do the drainage, if you put this irrigate the syringe, and there is a reflux from both the lower punctum and the upper punctum as well, then and there is a soft spongy feeling, that it means that obstruction is at the common canaliculi. So next is the Jones dye testing. So basically, Jones dye testing is done when you do the irrigation syringing procedure, but patients still complain of high epiphora, mean the watering from the eyes. So then you can perform the Jones dye testing. So what will the Jones dye testing will rule out? It will rule out three things. It will rule out hypersecretion of the tear. It will rule out the partial nasolacrimal duct obstruction, and it will also will rule out the lacrimal pump failure. So lacrimal pump failure is basically due to the because the orbicularis muscle surrounding the eye is not working properly, so that is why the tears are not being drained. So Jones dye testing is indicated only in patient with suspected partial obstruction of the drainage system. Epiphora is present, but there is no punctal abnormality, and the patient tastes saline in his or her throat on irrigation. So there will be the primary test and there will be the secondary test. So the primary test differentiate the partial obstruction of the lacrimal passage and the lacrimal pump failure from the hypersecretion of the tears. A 2% of the fluorescein is instilled into the conjunctival sac for of one eye only. For after about 5 minutes, a cotton tip applicator but moisture in a local anesthetic is inserted under the inferior turbinate at the nasolacrimal duct opening. The results are interpreted as follow. Positive fluorescence recovered from the nose indicates the patency of the drainage system. Watering is due to the primary hypersecretion and no further tests are necessary. Negative is no dye recovered from the nose indicate a partial obstruction, site unknown, or failure of the lacrimal pump mechanism. In this situation, the secondary dye test is performed immediately. There is a high false negative rate, that is, a dye is commonly not recovered even in the presence of the functionally patent drainage system. Modification involve the direct observation of the oropharynx using a cobalt blue light for up to or may reduce the false negative rate almost to zero. So basically, I told you earlier that basically the Jones dye testing give us the differentiation between the three things: hypersecretion, lacrimal pump failure, and partial obstruction. So what happened in the primary Jones dye test is basically just put the dye into the conjunctival sac and you put the anesthetic cotton bud into the inferior turbinate. After that, you recover. You see that after 5 minutes, if you see the dye in the nasal the cotton tip, it means that that a lacrimal drainage system is patent and there is no problem in the drainage system. Rather, is due to the hypersecretion of the um, hypersecretion of the tears. So we rule out this thing, that this is not normal. But the other thing is, uh, if it does not happen, if it does not happen that if you put the cotton tip applicator and there is no dye that is formed, then there are two possibility: either it is due to the partial obstruction and either due to the lacrimal pump failure. In both of these, we will perform the secondary Jones dye testing. So false negative rate means sometimes the lacrimal drainage system is patent, but you are unable to receive the dye on the cotton tip. So what you do is basically you put the cobalt blue light into the oropharynx, and if you see the dye in the oropharynx, it means that our lacrimal system is patent. So next is the secondary Jones dye testing. So basically it is an irrigation. The secondary irrigation test identifies the lacrimal pump failure or the probable site of the partial obstruction on the basis of whether the topical fluorescein instilled for the primary test entered the lacrimal sac. Topical anesthetics is instilled and any residual fluorescein washed out from the conjunctival fornix. The drainage system is then irrigated with a cotton bud under the inferior turbinate. Positive fluorescent stained saline recovered from the nose indicate the fluorescent entered the lacrimal sac, thus confirming the functional patency of the upper lacrimal passages. Partial obstruction of the nasolacrimal duct distal to the sac is inferred. Negative unstained saline recovered from the nose indicate the fluorescein did not enter the lacrimal sac. This implied the upper lacrimal, punctal, or canalicular dysfunction, which may be due to the partial physical occlusion and or like pump failure. So basically, in a secondary Jones dye test, you do the irrigation. So it is based on the primary test that you put the sac, the you put the um, dye into the conjunctival sac. It means that if it entered the lacrimal sac or not. In a case of lacrimal pump failure, because the dye did not enter the lacrimal sac at all, it will but in a case of partial duct obstruction, there will be some kind of dye that will be enter the lacrimal sac. So what you do is basically you remove the any stained conjunctival sac fluorescein and you irrigate it. So then you see the cotton bud applicator. If you recover the dye from the cotton bud, it means that there is a partial obstruction at the nasolacrimal duct. But if you do not recover any dye, it means that there is a lacrimal pump failure. Next is a contrast. So this is showing 3.8 is showing the drainage test showing 2% fluorescence in the left nostril only, confirming a patent nasolacrimal duct on that side. Next is a contrast decreocystography. Decreocystography DCG involves the injection of the radio opaque contrast medium at iodized oil into the canaliculi, followed by the capture of the magnified imaging. Indication include the confirmation of the precise site of the lacrimal drainage obstruction to guide surgery and the diagnosis of the diverticuli, fistula, and filling defects, stones, and tumor. It should not be performed in the presence of acute infection. A DCG is unnecessary if the site of obstruction is obvious, for example, regurgitating mucocele. A normal decreocystogram in the presence of a subjective and objective epiphora suggests the failure of the lacrimal pulse. This is more rarely demonstrated by the simple irrigation. So basically, this is the decreocystography. So basically, what you do is you put an iodized or I a iodized oil into the eye, into the lacrimal drainage system by syringing, and then you track it with the films. So if there is a patent drainage system, you will see the track of all the dye. But in case of a non-pendency, you will see that the dye will remain at some kind of obstruction, and you will know that there is an obstruction. And in that case, you can also DCG can also give us fistula, diverticuli as well. So 3.9 decreocystography is showing the conventional DCG without subtraction, showing normal filming on both sides. B is showing normal left filling and obstruction at the junction of the right sac and nasolacrimal duct. Digital subtraction showing similar imaging to the B. Next is the nuclear lacrimal scintigraphy. So this is a physiological condition, a more physiological condition to detect the drainage system abnormality than a DCG. Why? Because you just stain the tear with the radioactive substance, and then you see the passage of the tears. So scintigraphy is a striate drainage under more physiological condition than DCG by labeling the tear with the radioactive substance and tracking their progress. Although it does not provide the same detailed anatomical visualization as DCG, it may be used to identify the location of a partial or functional block. For example, indicating the absence of the significant tear entry to the canaliculi, localizing the site of physiological obstruction to the eyelid. To confirm the functional obstruction, or sometimes to confirm the presence of a normal drainage, such as that surgery is not indicated. So basically, nuclear scintigraphy is you just stain the tear with the radioactive substance, and then you see that how it drained. So nuclear lacrimal scintigraphy showing passage of the tracer via the right lacrimal system but obstructed drainage at the left nasolacrimal duct. Scintigraphy allows the tear drainage to be assessed in the physiological condition and may be helpful to identify the location of a partial or functional block. Next is a CT scan and MRI. CT and computed tomography, CT and MRI magnetic resonance imaging are occasionally employed in the assessment of the lacrimal obstruction. For example, for instance, in the investigation of the paranasal sinus or suspected lacrimal sac pathology. Internal nasal examination assessment of the nasal cavity, especially with endoscopy, can be invaluable in the detection of obstruction such as nasal polyp or a deviated septum. So next is that we acquired obstruction. So acquired obstruction is basically the obstruction which are acquired due to aging process or due to trauma or due to any other pathology of the eye that causes the obstruction for it. So number one is a conjunctival chalasis. So conjunctival chalasis is basically a loose redundant conjunctiva that is between the lower eyelid margin and the sclera. So what happens is basically these conjunctiva, loose redundant conjunctiva, blocks the punctum and causes the obstruction of the lacrimal drainage system. So conjunctival chalasis is characterized by one or more fold of the redundant conjunctiva prolapsing over the lower eyelid margin. It can exacerbate the symptoms of dry eye and commonly contribute to epiphora, of which it can be under recognized cause. It is thought to be predominantly an involutional process involving the loss of conjunctival adhesion to the underlying tenon capsule. So basically this is an age related process in which there is a loosening of the conjunctival adhesion to the underlying tenon capsule and episclera, and may be analogous to the conjunctival abnormalities leading to the superior limbic keratoconjunctivitis. Chronic low-grade ocular inflammation, for example, dry eye blepharitis, is likely to play a role if severe exposure of a redundant fold can occur. Observation or lubricants in alone may be appropriate. In mild cases, topical steroid or any anti-inflammatories can be used. Surgical options include securing the bulbar conjunctiva to the sclera with the 3 absorbable suture, for example, 60 polyglectine, placed 6 to 8 mm from the limbus or excision of the crescent shaped area of the excess bulbar conjunctiva with an interior limit of around 6 mm from the limbus. Suturing the edges of the excised patch together or replacement with the amniotic membrane has been described. So basically you can treat it with some, you can just use the lubricants, you can also use some kinds of steroid, mild steroid, but major procedure is the surgical. Basically you excise the conjunctiva below 6 to 8 mm below the limbus, and after the removal of patch you can just suture the rest of the conjunctiva, or you can use the amniotic membrane transplant for the excised for the bare sclera. Next is the primary punctal stenosis and a secondary punctal stenosis. So primary and secondary punctal stenosis. So the difference between is basically ectropion. Because the primary punctal stenosis, the punctal stenosis is there as it is. There is no eversion of the puncta that is causing the stenosis. Whereas secondary punctal stenosis, there is an eversion ectropion which is causing the stenosis of the puncta. Basically, the treatment of both are a little bit of different. So primary stenosis occur in the absence of the punctal eversion. The most common cause are the chronic blepharitis and idiopathic stenosis. So idiopathic means there is no cause. Other causes include herpes simplex, herpes zoster lid infection, local radiotherapy, cicatrizing conjunctivitis, chronic topical glaucoma treatment, systemic cytotoxic drugs such as 5-fluorouracil, and rare systemic conditions such as porphyria cutaneous tarda. So these are some of the causes that can occur that can contribute to the primary punctal stenosis without any presence of a punctal eversion. Dilatation of the punctum alone can be tried but rarely gives the sustained benefit. Punctoplasty is usually required. A number of techniques have been described, including 1, 2, or 3 snip enlargement with the removal of the posterior ampulla wall, and a procedure using a mechanical punch, laser, or a microsurgery. A temporary stent can be used. So So basically, what can you do in a case of a punctal stenosis? You can just dilate it with the punctum dilator, or you can use a snip procedure. Basically, snip procedure is basically, that there is a punctum and it has a posterior wall and an interior wall. So what you do is basically you cut the posterior wall either by giving one incision, which is called one snip. You can give two incision, which is called two snip incision, and you can give three incision, which is like three snip procedure. Basically, it uh, gives the increase, dilate the punctum and giving the more room for drainage. And this is known as punctoplasty. So this is, you can see the snip procedure. A is showing the technique and B is showing two snip A technique. B is showing post operative appearance arrowheads. So basically you just take the take the scissor and you just cut the punctum, like first on this side and then this side and then this side and this side. And sometimes you can also use the mechanical punch, laser or microsurgery as well. And after that you can give the temporary stand. Whereas secondary punctal stenosis, you do not have to treat the punctal stenosis. You have to treat basically the eversion of the lid, which is basically causing the punctal stenosis. Secondary stenosis occur after the punctal eversion lead to the chronic failure of the tear entry, and punctoplasty is usually performed in conjunction with the correction of the eversion. So you first have to correct the eversion and then you treat the stenosis. Retropunctal or Ziegler cautery can be used for the pure punctal eversion. Burns are applied to the palpebral conjunctiva at approximately 5 mm below the punctum. Subsequent tissue shrinkage could invert the punctum. So basically what you do is basically you, so for example, this is a punctum and you can see that this is a eyelid. So what do you do? Before, below the 5 mm of the puncta, you measure it with the caliper and you place the burn on it. And what it causes is basically causing the shrinkage of the conjunctiva, which is causing the inversion of the eyelid. It is known as a retropunctal cautery. Second is a medial conjunctivoplasty, can be used in a medial ectropion of the larger area of the lid if there is no substantial horizontal laxity. A diamond shaped piece incision of the tarsoconjunctiva is excised about 4 mm high and 8 mm wide, parallel with and infralateral to the canaliculus and puncta, followed by the approximation of the superior and inferior margin, wound margin with sutures. Incorporation of the lower lid retractor in the suture further aid repositioning. So basically you treat the eversion by making the diamond shape excision, and after the diamond shape excision, basically you remove the part of the conjunctiva and tarsal, and then you suture it. And if you take the retractor with it, then it is more helpful. So basically you are shortening the conjunctiva and tarsal so that there is an inversion of the eyelid. So you can see the figure this. So this is showing the medial conjunctival plasty. There is a diamond shaped excision and then you can suture it with it. So that's it. Next is a lower lid tightening, usually with the tarsal strip, is used to correct the lower lid laxity and may be combined with the medial conjunctival plexus where there is a significant medial ectropion component. So if there is a horizontal lid laxity and there is an ectropion, you can do the tarsal strip procedure as well. And if there is a significant medial ectropion, you can combine it with the diamond shaped excision as well. Next is the canalicular obstruction. Causes include congenital trauma, herpes simplex infection, drugs, and irradiation. So these are some of the causes of the canalicular obstruction. Chronic cystitis can cause a membrane to form in the common canaliculus. The initial surgical procedure has been tended over recent years to attempt to preserve the physiological anatomy. So there is a partial obstruction and there is a total individual canalicular obstruction. So, in case of a partial obstruction of the common or individual canaliculi or anywhere in the lacrimal drainage system, may be treated by simple intubation of the one or both canaliculi with the silicone stents. They are left in situ for 6 weeks to 6 months. So basically, what you have to do is in a partial canalicular obstruction is you take the silicone tube and you put it into the lacrimal canaliculi for about 6 months, so it will remove the partial obstruction. Especially in case of a dacryocystitis, we do not place the tube. We place the tube when there is a chances of the partial obstruction of the canalicular system as well. In that case, we put the um, silicone tube. Next is a total individual canalicular obstruction. Canalicular trephination, usually a purpose made miniature made mini trephine sisler followed by intubation. Trephination has also been described using an intravenous catheter with a retracted introducer needle used as a stunt and then advanced to overcome the obstruction. Balloon canaliculoplasty or endoscopic laser techniques are available. These less invasive options may have a lower success rate than a more aggressive surgery. So basically what happened is that in a case of a lacrimal drainage system, in a canalicular obstruction, for example, this is a canaliculi and here is an obstruction. So what you do, you can take an instrument known as sisler, or you can take a catheter as well. So what you do is basically you go without catheter have a needle and and above it is there is a plastic tube. So you take the plastic tube, you advance it, and when you know that there is an obstruction, you proceed the needle and you cut the obstruction, and after that you place the any stunt or tube, and this is how you overcome the canalicular obstruction. With 6 to 8 mm of the patent normal canaliculi between the punctum and the obstruction, anastomosis of the patent part of the canalicus into the lacrimal sac with intubation can be performed. When obstruction is severe or it is not possible to anastomose the more functioning canaliculi, to the lacrimal sac, conventional surgery consists of a conjunctivo-dacryocysto-rhinostomy and the insertion of the toughened glass Lester-Jones tube. This may also be used when the lacrimal system is intact but non-functional due to the failure of the physiological pump. For example, facial nerve palsy. The surgery is performed for the external approach dacryocysto-rhinostomy, but the truncle is excised and the track for the tube created between the ligus lacrimus and the lacrimal sac. Patient satisfaction is variable. So basically it is trying to say that this is a lacrimal drainage system of the canaliculi. So whenever there is an obstruction that is about there is a patency of 6 to 8 mm, so what you can do, you can do the you can directly anastomose the patent part of the conjunctiva to the lacrimal sac in the tube. But if the obstruction is less than that, you will have to perform a procedure through which you do the procedure in which the conjunctival you make a fistula between the conjunctiva, then lacrimal sac, and then to the nose. This is known as a conjunctivo dacryocysto-rhinostomy, and after that you post a Lester-Jones tube. So this is a Lester-Jones tube, and CT scan shows the 3D reconstruction. Next is a nasolacrimal duct obstruction. So there can be causes, idiopathic causes, stenosis. By far the most common cause, nasoorbital trauma, including nasal and sinus surgery, granulomatous disease such as granulomatous with polyangiitis, vaginal disease, and sarcoidosis, infiltration by the nasopharyngeal tumors. So because the vaginal and sarcoidosis, when they usually are the sinus diseases as well. So whenever there is a sinus disease, there can be the nasolacrimal duct obstruction with it. So how will you treat? So you can treat it with conventional external approach. Decrecysto-rhinostomy (DCR) is indicated for the obstructed distal to the medial opening of the common canalicus and the consist of the anastomosis of the lacrimal sac to the mucosa of the middle nasal meatus. So very important, because normally that nasolacrimal duct system is open into the inferior meatus, but in case of a TCR we make a fistula between the lacrimal sac and the middle meatus. The procedure is usually performed under hypointensive general anesthesia. Vertical skin incision is made 10 mm medial to the inner canthus, the medial canthal tendon and the lacrimal sac exposed and reflected, and after the removal of the intervening bone, the sac is incised and attached to the opening created in the nasal mucosa. The success rate is over 90%, but the causes of a failure include inadequate size and position of the ostium, unrecognized common canalicular obstruction, scarring, and the SAM syndrome, in which the surgical opening in the lacrimal bone is too small and too high. Complications include cutaneous scarring, injury to the medial canthal structure, hemorrhage, infection, cerebrospinal fluid, rhinorrhea if the subarachnoid space is uh, inadvertently entered. So basically, in a case of a cystodynostomy is basically a procedure which we do for the nasolacrimal duct obstruction, NLD blockage. So what you do is basically first you put the skin excision that is basically 10 millimeter below the, behind the medial canthi, and after that you expose the muscle, and then you expose the nasolacrimal sac, lacrimal sac, and then you um, separate it from the bone, and then you make a bony incision. After that bony incision, it will expose the nasal mucosa. After the bony excision, you will see that there will be the nasal mucosa. So, and then there is a lacrimal sac. So what you do is basically you make an H shape excision in it, and then you make the both of the so you make an opening in the lacrimal sac, and then you make an opening in the nasal mucosa, and then you basically tie the nasal mucosa to the lacrimal sac, so the whenever the tear is drained, they directly go to the nasal mucosa. After that you close it, and then you put the suture. You can also place the tube in it for any kind of suspicion of the partial obstruction. So this is a technique for the decusistinostomy, a vertical skin incision made 10 mm medial to the inner canthus, avoiding the angular vein. The interior lacrimal crust is exposed, and the periosteum is divided from the spine on the interior lacrimal crust to the fundus of the sac and reflected forward. The sac is reflected laterally from the lacrimal fossa. See, the interior lacrimal crust and the bone from the lacrimal fossa are removed. So you can see the bone is being removed, and you can see that there is a nasal mucosa exposed. The sac is incised in an H-shaped fashion. H-shaped manner to create two flaps. A vertical incision is made in the nasal mucosa to create the interior and the posterior flap. The posterior flaps are sutured, the interior flaps are sutured. So how will you basically make a flap? H-shaped flap is basically you make an incision here, and then you make an H-shaped flap here. So what it will do is basically when you make an H-shaped flap, it will make two flaps like this in both of them. And same in the case of a nasal mucosa, you will make an H-shaped flap, so like this. So it will, what it will do, it will also make two flaps. So what you do is basically you tie the posterior flap first, and then you tie the interior flap, so it is basically a continuous drainage. And then after that you close, suture it, and then you suture the muscle, and then you suture the skin. Then there is an endoscopic TCR. Endoscopic TCR encompasses several techniques. A light pipe can be passed through the canalicular system into the lacrimal side, guide to an endoscopic approach from within a nose, or a microendoscopic transcanalicular procedure can be performed using a drill or laser to establish the communication within a nasal cavity. Advantage over the conventional DCR is much less marked. Systemic disturbance with a minimal blood loss and a lower risk of the cerebrospinal fluid leakage, and the avoidance of the skin incision and generally shorter operating time. Disadvantage includes generally a lower success rate in visualization. Difficulties, meaning the additional procedures are sometimes needed. Other procedures often reserved for partial nasolacrimal duct obstruction, including probing and intubation, stent insertion, and balloon tracheocystoplasty. So basically, there are certain complications of the DCR as well. So what are the complications? There can be the failure of the procedure, there can be the inadequate position of the ostium, so you did not drill the bone much adequately, and there is a narrow opening, and there is a some syndrome in which when the lacrimal bone is too when you do the surgical opening, that is too small and too high, and there can be the scarring of the cutaneous tissue. There can be this medial canthal tendons structure damage. There can be hemorrhage, infection, and there can be even the, if you uh, enter the anterior cranial fossa, it can cause the CNS rhinorrhea as well. And next is an endoscopic DCR. Basically, you make the surgery through the nose. What happen is basically you put the light pipe into the nose, and you do all the procedure from the nose instead of from the skin. So you make the uh, uh, bony formation from here, and then you make the lacrimal sac incision from it, and then you can put the tube in it and was. So basically through the nose you do the procedure. Next is tracheolithiasis, is basically the stones. Lacrimal stone may occur in any part of the lacrimal system. They are more common in males, although the pathogenesis is unclear. It has been proposed that the tear stagnation secondary to the inflammatory condition obstruction may precipitate stone formation, which tends to be associated with the squamous metaplasia of the lacrimal sac epithelium. Presentation is often in late adulthood. Symptoms include intermittent epiphora, recurrent attack of the acute decuscystitis, and a lacrimal sac distension. The lacrimal sac is distended and relatively firm, but is not inflamed and tender as in acute decuscystitis. Mucus reflux on pressure may or may not be present. Treatment involves a DCR. So basically, there is a stone formation like any other sac, like gallbladder sac. There can be the formation of stone, or basically the stones are formed because the of the tear stagnation or due to obstruction of the nasolacrimal duct and inflammation. There are changes in the lacrimal sac epithelium, and there is a metaplasia which is causing the stone formation. And basically when the stone is formed, the lacrimal sac is basically firm and distended, but it is not tender as in the case of acute decuscystitis. And the treatment is basically who do the DCR procedure in it as well. So that's it for the lacrimal drainage system part 2. See you in the next lecture.